Hello, welcome to this lecture on Introduction to Preventive Medicine. It is the first chapter in Section 3 of Jekyll's textbook, Epidemiology, Biostatistics, Preventive Medicine, and Public Health. It appears as the first chapter in the section titled Preventive Medicine and Public Health. So this will be a good overview of the art, the science, and the practice of population, public health, and preventive medicine. When we talk about a disease, we talk about the natural history of the disease. You might hear that word or that phrase, natural history of the disease, in anatomy and physiology or pathophysiology. And basically, the natural history of the disease, of a disease, is that it's in a pre-disease state, a latent state, and a clinical phase state. Meaning, in a pre-disease state, there is no disease at all. There is no genetic or any cause of a disease, not yet. In the latent phase, where a disease could be asymptomatic, you might have a risk factor for a disease. You might be exposed to a risk factor, and this is where you may not have any signs or symptoms, at least symptoms. That's why this is asymptomatic stage. And then lastly, there are signs, and there's also symptoms, or it's symptomatic. There are interventions at each of these phases. There's the levels, what we call the levels of prevention in health promotion and in public health. You've already heard this probably numerous times, and some examples of, for example, primary prevention, secondary, as well as tertiary prevention. So primary prevention are things like health promotion, lifestyle modifications that might also look like a policy that's been implemented. Secondary prevention are screenings that would offer to detect and identify a disease before it damages tissues or organs. And then tertiary prevention is when the disease is present and there are symptoms, and now you need pharmaceuticals and drugs and perhaps surgery to slow or reverse the damage. And then in primary prevention, pharmaceuticals can be used in primary prevention. A good example of that is vaccination, water fluoridation, as well as in nutrition. So similarly, in secondary prevention, a screening can certainly slow, stop, or reverse the clinical progression. And then lastly, in terms of tertiary prevention, there are treatments to prevent further injury and minimize disability, which we'll further go into in the next several slides. And I know you're all familiar with actually some of these interventions, especially at the primary level, where healthy diet, exercise, and smoking cessation can be represented in all the stages. But obviously, with respect to chronic diseases and specific risk factors like smoking, specific risk factors like an unhealthy diet or physical inactivity, that these can definitely prevent or even reverse disease states. And this is a nice overview of what we term preventive medicine or population health, and looking at these levels of prevention. The primary prevention, whether it's the pre-disease state, that you don't have the disease yet, it's not symptomatic. Perhaps in terms of obesity, you are in the normal BMI range. And so when somebody is in the normal BMI range, they're kind of in this pre-disease state for obesity. Then we talked about latent disease or secondary prevention stage, where screening can be an impactful factor for example, screening for cancer, screening for STDs, sexually transmitted diseases, screening for hypercholesterol, screening for high blood pressure. So those are other examples of latent disease where you can conduct secondary prevention, which I just mentioned some of the assessments that some of you have done in some of your courses already. And then finally, when the disease does progress, you are in a clinical disease state where tertiary prevention has to be utilized, and where you're trying to limit the disability as well as do rehabilitation. And just to give you a preview of the economics of public health and preventive medicine, we know that services, products, programs that are related to tertiary prevention, that these services and products are very costly compared to the primary prevention stage, where cost could be quite a bit less and the impact or benefit quite a bit more, especially when you think about preventing people from progressing into these chronic diseases such as cardiovascular disease, heart disease, respiratory diseases, neoplastic diseases, cancer, that the primary prevention can be so beneficial in not only stopping and moving the disease forward, but limiting the cost on society in an economic and financial manner. These are just another table that shows another view and some examples of the potential medical responses with respect to the level of prevention, and then, of course, the disease, the stage of the disease. So, for example, when we know that it's in the pre-disease state and there are no risk factors, that you're conducting primary prevention and you're just encouraging, conducting, promoting health promotion and encouraging healthy behaviors. Similarly, in primary prevention, in terms of disease susceptibility, you might utilize specific protections like immunizations, supplements, safety, policy development, and policy implementation of specific programs that could be also be underscored in this area as well. And we've talked about secondary prevention associated with screening, and of course disability and rehabilitation associated with tertiary prevention. So when we think about prevention and treatment, and you can kind of associate prevention with, again, primary prevention, and then we can associate treatment with that tertiary prevention stage, that it's going to be a lot more costly. So when you think about the programs or services in prevention, you want to consider the incidence or prevalence of the disease in the population, meaning how many people are affected. If it's a chronic disease, we know that chronic diseases take up a lot of healthcare resources, and it's also very costly. When we think about the treatment for these said chronic diseases, again, thinking about the incidence of the disease, well, from a tertiary treatment, we know that the cost of the treatment to society and individuals is outrageously expensive compared to potential life-saving policies and prevention measures that could be helpful. So for example, in tobacco and cigarette use, the policies that have helped lessen the use of cigarettes, whether they be smoking bans or higher cigarette taxes, that has certainly decreased the population of those who are smoking, and that has the cost have been much less compared to treating somebody who might suffer from COPD, chronic obstructive pulmonary disease, asthma, and other related diseases with respect to smoking. So the cost, another example at the very bottom here is the cost of vaccination is less than the medical and societal costs of preventable morbidity and mortality in large segments of the population. So meaning vaccines have been very cost effective in terms of not only preventing harm, but also uh, minimizing the cost financially. These are just some potential obstacles and barriers in providing some prevention methods. One reason why health promotion and primary prevention is sometimes not acceptable is that it hasn't gone through the rigorous studies that medicines and pharmaceuticals have gone under, like randomized control trials. So one reason why we can't do randomized control trials in preventive medicine is that my example of tobacco and smoking bans and increasing the price of cigarette, well, we can't randomize which segment of the population is going to be the smoker or not. We can't do what we call a prospective study on some public health practices. They have to be retrospective. And sometimes retrospective studies, although it has its limitations, there are some of its benefits, like it is easier to conduct from a cost standpoint and from a resource standpoint. The other hurdle includes some diseases are just so multifaceted. Again, with some of these chronic diseases, we know that it's not just one thing. It's not just a lack of physical activity. It's also nutrition. It could also be genetics. So kind of thinking about all the factors, both genetics and environmental, that are barriers in kind of pinpointing the problem with a particular disease. And then the last thing, disease research is largely supported by pharmaceutical companies. So far in this age of medicine, there is such a strong financial incentive to treat rather than prevent the disease. So far, our healthcare system has in the past been solely based on fee for service and treating the disease so that people make money when people are sick. And so what healthcare reform is trying to do, such as the Affordable Care Act, aka Obamacare, is to pay for healthcare from a truly outcomes and value-based standpoint. Meaning we're not going to pay the provider, whether it be pharmacist, clinician, medical doctor, we're not going to pay them just because they are providing a product or service for everybody who is sick, but instead we're going to pay the provider based on, did you actually improve health outcomes? Did you actually improve their blood pressure, their cholesterol, their A1C? So that is obviously with healthcare reform and health policy, that is a whole topic in of itself, but is very important when we talk about public health, population health, and preventive medicine, which is a focus in healthcare reform and the Affordable Care Act. So some things to consider when we think about the economics of prevention, or what are the priorities? So justifying the cost to address issues that are not a problem yet. So sometimes it's hard to come up with policies where if you're not obese, we don't need to have anti-obesity programs. But of course, we know that that's obviously contrary. But some, in a political sense, that could also be a dangerous political game that legislatures have to play. Economics, anytime we do economic analysis, we have to talk about the delay of benefits and discounting. Again, sometimes a program or a service, a policy, it takes a while to take into effect. And so who wants to wait? So definitely utilizing evidence-based medicine, utilizing research, utilizing statistics to forecast these benefits is the era of big data, data mining, and health informatics. And lastly, accrual of benefits. Who's going to benefit? Again, kind of similar to the priorities. Sometimes who actually benefits can be a not only legally charged but politically charged issue. And then finally, obviously, is the prevention worth it? When we talk about many of these healthcare programs and public health policies and preventive medicine tools, yes, especially when we're talking about the chronic diseases, it's going to be very impactful and worth it. Just to give you a little taste of some of the types of health economic analysis. Again, this is the area of pharmacoeconomics in the pharmaceutical realm, just healthcare economics, just more broadly speaking. You can see that there are several types: cost minimization, cost effectiveness, which you might have heard in the past already, as well as cost benefit analysis and cost utility analysis. All these three are very similar in terms of, if you look at the formula down here, this formula, the ICER formula, is an incremental. ICER stands for incremental cost effectiveness ratio. So you're conducting this analysis by basically looking at the cost of the drugs, comparing, for example, a control drug versus the new drug, drug A versus drug B, and the effects of the drug A versus drug B. So as an example, if it's a anti-hypercholesterol medicine, did it lower the lipids? Lastly, with respect to the types of economic analysis that I just mentioned, some of the other indices that we would utilize in analyzing, for example, a cost-benefit ratio. In population health, when we look at the population, we can measure how long are you living, or how much life did you actually lose as a result of the disease. And then we can also, when we need to, do some calculations of a utility. We can determine death rates, and we can make sure that we're adjusting them appropriately. So these measures can give a snapshot of the health of a group of people based on their age at death rate. From an individual health standpoint, we can assess their general well-being. There's many different assessment tools, questionnaires, surveys that measure this general well-being, as well as measuring daily activity, and then another type of assessment that looks at quality of life. So these incidences consider patients' individual perceptions as to how the disease and disability affect the quality of their remaining years. So to summarize, preventive medicine seeks to enhance the lives of patients by helping them promote their quality of life and their overall health. Again, kind of focusing on especially primary prevention. Preventive medicine focuses on preventing the disease of onset, slowing the progression of the disease, and limiting disability. And then, so what are some of the barriers? It's this third bullet point here. Sometimes long delays between preventive investments and returns make it difficult to prove that an ounce of prevention is worth a pound of cure. But I think we're slowly moving towards more of this rather than away from it. And then understanding that health is an elusive concept. It is not just physical, it is mental, it is social. And it's just more than just about the absence of the disease. It also includes the ability to adapt to these stressors, because we all as individuals adapt to these different stressors.